So mindfulness, non-judgmental awareness of the present moment. And essentially, during the 8-week course, that is what is done, is that people are introduced to a series of present moment exercises, starting with awareness of the breath, moving on to awareness of the body, awareness of sounds, and then later on in the 6th, 7th, and 8th week, awareness of thoughts and feelings as we begin to move into the cognitive part of the course.
So, yeah, we had a bursary-funded, just a very small project to really, we had a couple of aims, was to investigate the clinical effectiveness of MBCT within a primary care setting. And also to really explore with the local GPs, is this feasible? What was the feasibility of actually all of the administration and, if you like, the kind of the hardware of the project? Was that going to work? So we began by just giving a talk to local GPs. GPs came along and we talked to them, gave them an introduction, a little bit like Gareth has just talked to you about mindfulness and how MBCT might be helpful. And then we invited them to refer into our project. And once the referrals started to flow, and at that point I was starting to look at the referrals and make assessments. When the flow of referrals died down a little, we sent out a reminder letter. Once I got the first referrals, I then would contact patients and have a brief conversation with them. And that proved to be quite important because the GPs had only had a very, very brief introduction. So they weren't really in a position to explain to patients what they were being referred into. So that very first phone call was really me really saying, this is what's involved, this would be your commitment to it. One of the things that Gareth didn't mention was that this course actually requires quite a bit of homework, quite a bit of home practice. So it's really important that you get people in the group who have bought into the approach as best they can. So I would have a brief 10-minute phone call with them, and then if they were still up for it, then they would come and see me, and I would do a more detailed assessment interview with them. So over some months, I did 31 assessments, and after that we recruited 17 participants. So the people that I excluded were people who had recent trauma and loss. What we know is that mindfulness invites people to really focus their attention inwards. It's not necessarily helpful for everybody, and this would be a group that perhaps would be best actually left to let the normal grief and loss process work its way out. Mindfulness is generally more helpful for people perhaps who've got stuck in that process. So I was excluding people who come with some recent trauma. Some people who are currently severely depressed, I didn't feel would have the energy to actually engage with the program. And again, I was making kind of intuitive decisions here. It was also really important for me to explain to people the level of commitments, the home practice, the necessity to come to all of the 8 sessions as best they could. So, you know, once we talked that through, and some people's lives were very complex, and it just wasn't the right time for them, so some people dropped out for that reason. So this was the kind of the profile of the group that we had. People with, the average age was 47, 10 out of the 17 had previously had some psychological treatment, and there was a mixture of people with depression, anxiety, and chronic fatigue syndrome, and as you might expect, some of them had combinations of those. So here it gets complicated. Well, it does to me anyway. But basically what this shows is that pre-intervention, that blue line across your screen there is, above that is possible cases, above the red line is probable cases. So you can see that there were 6 probables before treatment and 2 possibles and 7 subthreshold. Following treatment, immediately post the intervention, there was only 1 probable case, 1 possible, and 13 below. So 6 had dropped below the threshold as a result of the intervention, we think. So that was for depression. Very similar picture for anxiety. And then this is the 6-month follow-up. So what we can see is that there's a sharp decrease in symptoms for anxiety and depression immediately post-treatment, and then a very slight rise at the 6-month follow-up. So the decrease between the baseline and the immediate post-treatment is statistically significant. The slight rise after, at the 6-month follow-up, actually isn't statistically significant, which I'm told is important. And in fact, to kind of put it into a human level, that rise is probably accounted for by one person who had something of a relapse during that 6-month time. And these were some of the summary of the findings that the GPs replied with. So there was a general support for a shift to more preventative methods for dealing with mental health problems. Many thought that primary care was a suitable place for MBCT interventions. Many thought that they would regularly refer patients in if such a service existed. What came up in the original referrals was that once GP counsellors had got to hear about it, I was getting quite a few referrals from the counsellors in primary care and not just from the GPs, and that led us to think about maybe they would be, in the future, they would be perhaps the people who might train to deliver this as an intervention, and they certainly would perhaps help with the assessment process and the information giving process for patients. What we know just from this pilot is that it appears to be effective for individuals with a mild and moderate depression. What we know from MBCT research generally is that there is an improvement in rumination patterns, sense of self-compassion and well-being. So one of the threads that runs through the course is this idea of kindness and self-compassion, and it's implicit throughout the whole course. And so it's one of the things that we measure when we're measuring the effectiveness of mindfulness-based approaches, both MBSR and MBCT, is have people made a shift in attitude towards themselves and their symptoms. And generally, GPs were supportive to developing this further, to perhaps increasing the availability of it.
The primary reason for doing it in the first place was really just to explore what would happen in a primary healthcare setting. You know, would we get referrals? Would GPs refer? Was it entirely appropriate for a primary healthcare setting? And certainly I think our overall conclusion is that it is. Mindfulness sits very comfortably in a primary healthcare situation, certainly much more so than in a secondary healthcare model as that which John Kabat-Zinn runs in Massachusetts. We identified the fact, without doubt, that you need the expertise. A mindfulness teacher, it takes a while to get into it, to understand it, and to teach it. Interestingly, you can do a degree in psychology and teach CBT, for which there is robust evidence, without actually practicing CBT yourself. You cannot do that with mindfulness. You have to be a mindfulness practitioner. It is a totally experiential course as such. The will, obviously, needs to be there. Venues, we do now in our locality have a number of improved GP practices that actually have education rooms large enough to accommodate up to 20 people for such an exercise. If not, then certainly the venues is an issue. One could look for local venues that are large enough to accommodate such a group. Preferably, though, we would keep away from trying to hospitalize the whole process if that were at all possible. There is, as you can appreciate, I'm sure, a lot of administrative work involved with this. It's not so much just the 8 weeks, it's all the letters and the liaising, the telephone calls, the pre-course interviews, and all the work that goes with that always has to be noted. There's a lot of hardware as well. There's, CDs, Eluned, these are Eluned's Mindful Movement CD, walking meditation, sitting meditation, body scan guided meditation, and stretch and breathe. So all these are handed out at various stages during the 8-week course. When I did my MBCT course back in 2002, it was all in one handbook. Now it's split into 8, one handbook for each week. The inclusion criteria is always going to be an issue for debate. We had a short time scale from the time we knew we had the money to the time we wanted this up and running, a period of about 4 months. So we decided to open the door to more than just people who'd had 3 distinct episodes of depression, and included people with general anxiety, chronic fatigue, and so on. So we had a bit of a mixed group, but they were all, without exception, vulnerable to depression, certainly. Language for us, in Carnarvon, it's the heartland of Welsh-speaking Wales, and 5 of the 16 people that completed the course took everything in Welsh. I mean, the handouts were in the Welsh language as well, so the translation service of the university was in busy use. Follow-up support is so important, and Bangor University run a Monday evening 2-hour mindfulness class once a month for anybody who has completed an 8-week course in MBCT. GP and healthcare provider awareness, well, of course, this is what this is about. Certainly my colleagues as GPs, I think mindfulness is becoming much more familiar, but there's always a lot of work really left to do with increasing awareness and increasing, certainly, the availability of mindfulness. And then finally, political awareness and funding obviously go together. And for the first time, literally 4 weeks ago, I say we as though I was certainly at the meeting, but Bangor University and the Betsy Cadwallader University Health Board, as it is now called, got together and were discussing mindfulness, specifically mindfulness, nothing else, in terms of how we could possibly develop this further. What model should we take, to go on to the inside and to ask the academic unit to train, let's say, primary healthcare counsellors possibly, to run 8-week classes from the inside and then reach out to patients that way? Or would we approach the academic unit and ask them to provide, let's say, 5, 6 or 7 8-week classes, perhaps across a range of venues in North Wales? Certainly, it seems to me, certainly I think, that one has with the results that we've had, the results that are now available, I think we have a professional responsibility, if not a moral responsibility, really, to try and provide mindfulness to people who would potentially benefit from it. I have absolutely no doubt myself, as I approach the end of my speaking slot, as they say, that this is, in my opinion, a golden opportunity for Wales to be right at the very forefront of healthcare provision and research. This is the first time, I think, anywhere ever that MBCT has been taught within a primary healthcare setting. It seems very, very comfortable. The people who benefit are those with, yes, of course, we know, chronic recurrent depression, but general anxiety disorder, chronic recurrent panic, obsessive compulsive disorder, chronic fatigue. I mean, it's primary healthcare stuff. And there is, and the academic unit in Bangor is truly, truly outstanding. Easier for me to say than Eluned, but it is. And it's so highly respected internationally now. It seems a shame that we can't. If they've got the expertise, we've got the patients, surely we must bring them together.